Decreasing Emergency Department Discharge Length of Stay, Courtney Siemens, Grand Canyon University, Leadership in Healthcare Systems Practicum. The agenda for this project includes an introduction, needs assessment, topic goals, outcome, sustainability, and a summary of the overall project. Introductions. Veterans visit the Syracuse VAMC Emergency Department with the expectation of expedited care for their illness and/or healthcare concerns. Often the ED services as a fail-safe resolution for the veterans to seek their health care. This emergency department flow project has the primary goals to focus on the promptness of service for our veterans seeking emergency care. We will be evaluating and smoothing the current process for the discharge length of stay. We believe that by doing so, we can make an impact on the overall ED system with throughput and patient care services. Primary goals: decrease the emergency department discharge length of stay. The length of time to discharge veterans to home from the ED has increased by 24 minutes over the past 3 fiscal years. Financial year 2020 was 158 minutes to fiscal year 2023, which is up to 182 minutes. Reasons for action. In the scope: consultation, surgery and psych timeliness, labs, imaging, discharged patients, and transportation. All of these areas were causing delays with the average length of stay in the emergency department. Out of scope were the ED observation patients, admitted patients, and patients who have eloped. Process start: arrival to the ED, the time that they're entered onto the EDIS tracking board. And the process stop time is the discharge to home and the time that they're taken off the EDIS tracking board. This is the current state of the ED discharge length of stay, broken up by the fiscal years. So fiscal year 2020 was at 158 minutes, 2021 was at 161 minutes, 2022 at 176 minutes, and then fiscal year 2023 and year to date is 182 minutes. Team members for this project include Dr. Mary DeRubo, who's the Chief Medical Officer, Sarah McNally, who's the ED Nurse Manager, Katie Hood, who's the Assistant Nurse Manager for the ED, Megan Kalala, who's the Specialty Program Manager, Amber Deos, the Social Worker, Lori Peterson is a Lab Representative. At the time of collaboration, still waiting on a representative from the Radiology Department, and then myself, Courtney Siemens, as the student. Timeline for this project: in May of 2023, they identified this as a primary problem. In June of 2023, key stakeholders were identified. In July of 2023, reasons for action were implemented. In August, a gap analysis was developed. Though this project will remain ongoing, the goal is by December 1st of 2023 to have a target length of stay back down to 150 minutes. As part of the gap analysis, problem sentences were developed. There's a delay in urine collection. Oftentimes, patients are using the bathroom prior to seeing the triage nurse. It was identified that there lacks specimen cup for collection in the waiting room. There's no signage indicating if you're here with abdominal pain or certain key symptoms of when they would need a urine sample, as well as orders put in for the urine collection. Another area identified as needing improvement is the lab specimen delivery batch. Oftentimes, labs are collected. They sit at the nurse's station waiting for other orders to be collected so that they can be transported to the lab in one batch. The lab is actually 2 floors away from the emergency department. So oftentimes batching the runs, because there's no dedicated runner or transport agent, they get delayed in results. The blood is received in the lab without orders, so the nursing staff takes it upon themselves to initiate care orders that would typically be identified for somebody who comes to the emergency department complaining of shortness of breath. They collect those labs prior to the provider orders. So the labs are drawn per a verbal order, and there's a delay in the actual physician putting the order into the computer. So the labs go with the rest of the batch to the laboratory, but there's no orders for them. Lab specimen requiring a redraw. So the majority of those specimens that sit down in the lab waiting for orders, or they sit at the nurse's station because there's no dedicated transport, often hemolyze or they clot, or maybe the patient's a really tough stick and they don't get enough volume of blood in the vials. Those specimens are being rejected in the lab. So just overall staff education on, how long the specimens are good for, inverting them after collection, and making sure that there's enough in each tube. Poor communication with consults. So the VA utilizes a larger hospital and residents and fellows from another institute to come over and consult for specialty areas. So oftentimes there's psych will come see a patient who's holding in the ED, but there's no communication as to the disposition that psych has come up with. Therefore, the ED staff are left in limbo waiting for the psych providers to put in a note indicating what the next steps are, whether the patient can be safely discharged or if the patient needs to be admitted to the hospital. There's poor communication with the consults in regards to they're busy with other patients in the larger institute and they don't return calls in a timely fashion. And there's no active callback log at the nurse's station to indicate if the consulting physicians or providers have called back. Some more gap analysis, delayed in transport to CT. So there's no transport off shift hours to transport these patients to the CAT scan. Another is for those that need IV contrast in their CAT scan. If they're a difficult IV stick or there's a delay in the blood collection resulting in a delay in the final results of those certain lab values. It was also identified that there's no ultrasound guided IV placement, which is also another delay. Delay in nurse provider implementation of order sets. No provider assigned to the patient during triage. So it takes the provider a little bit longer to assign themselves to their patient. And it was also identified that there are no standing order sets in the VA ED. Variability with provider and decision time. There's lack of consistency in care from one doctor to the next. And there's also a lack of ED pathway set orders that regardless of who your physician is, if you come in with complaints of shortness of breath, you get X, Y, and Z done automatically. And that would help expedite the care prior to the provider coming in to see the patient. Sustainability. This project was handed off to the ED management and leadership team. They really liked these ideas and want to have ongoing meetings to determine a completion plan, implementation, and then get insight from the staff on how they feel the project is going, if anything needs to be changed, and then what the final outcome would be. Professional goals. During this project, we identified the issues at stake here. We completed an overall gap analysis and timeline of events with an overall end date of December 1st of 2023. Professional communication growth and leadership teams. I was able to have collaboration with many different aspects of the ED leadership team, as well as leadership teams within the VA hospital itself. This is a huge professional growth interacting with all these different teams and hearing their insight on this project. AONL competencies. So the big piece with leadership is communication and team building. Now having knowledge of the overall healthcare environment, professionalism, and business skills. In summary, decreasing the length of stay in the emergency department will improve the overall care provided to our veterans. By doing this, it will make a huge impact on the overall ED system with throughput and patient care services.